Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. You'll go to the first update, please. So the first update, this is a 2-slide update, is that the 2023 SVAP process, which is the standards advancement process, went into effect this past Monday, September 11th. And so the following standards are now optionally approved for use by ONC. So you are not at this point required to use them, but if you want to, you may, and you will still be in compliance with ONC certification. You'll see the big thing is these are all related to going to USCDI version 3. So you have USCDI version 3 and the related US core version, and then I believe that the CCDA and QRDA documents are also related to upgrading the USCDI version. I'm not 100% sure on all of them that those are the only changes, but basically this is an update. But if you go to the next slide, they also, this is something they were not clear about in HTI1 when we looked at it. So they're actually removing stuff from the SVAP that had previously been supported. So basically this is the USCDI version 2 stuff. So if anyone had optionally certified against USCDI version 2, it will no longer be supported as of December 31st. And if that is the only thing they certified against, they will either have to go to USCDI version 3 or back to USCDI version 1. Testing tools for the new versions will not be available until December 31st, 2023. If you're, however, what they said is that if your product is currently certified, you can just attest to the USCDI version 3 support and be considered certified against it for now. You can find, which I thought was an interesting choice, but you can find more information on their standards version advancement process page, and there's links to information about specifically where these different standards are approved and how they're used and which certification involve them, etc. Any questions, thoughts, comments? All right, then let's move on to the next update. So as we have a new proposed rule out from OCR, and this is on trying to prevent discrimination on the basis of disability in healthcare. It actually officially posts tomorrow, but they put up a preview copy, which they do a lot of the rule, and so comments are due November 7th. We have not had a chance to look at it in any detail, but according to the introduction section, some of what it covers is it's basically it covers anyone who receives any type of HHS financial assistance. I guess that's the purview they decided they were allowed to cover. And you can't discriminate against the disabled in any way in any program. And they highlight 4 areas where they think discrimination is most likely, but again, it covers more stuff. One is medical treatment, one is use of assessments. Another, and this is a big one for certain disabled populations, is web, mobile, and kiosk accessibility. I will note that at the current time, many portals, particularly provider portals, are not fully accessible to the visually impaired and some other disabled communities, so that will be an interesting take. And then also the provision and use of accessible medical equipment. And I know there's some discussion of things like adjustable beds and accessible scales in the rule. I don't know what else they talk about specifically. But the idea is that it's meant to allow people with disabilities to participate in or benefit from all healthcare programs at an equal level that other people have the ability to participate. You can find the proposed rule there. It is again still in a draft state. It should magically move to a formal proposed rule tomorrow, and we will likely take a look at it later. Any questions or comments there? All right, well then let's move on to the next item, excuse me. So this was interesting. CAQH came out with what they call an insight report on good faith estimates. But what's particularly interesting is that the report is based on data from 2021, but the GFE requirement for uninsured and self-pay patients did not formally go into effect until January 1st, 2022. So this is sort of the voluntary preview data. And as we look at it, you'll see that there are portions of it that don't actually comply with the No Surprises Act rules for good faith estimates. And since those were not in place yet, that's totally fine. So what will really be interesting is if they do this report again next year to compare the data and see whether people have moved into alignment. But that said, and that also might explain why these numbers are so small. Because the on average during 2021, small groups of less than 5 physicians generated 19 good faith estimates throughout the year. Large groups of more than 5 physicians, they didn't specify where a group of 5 physicians falls. I don't know that it's that essential to know that, but pointing that out, generated 596 on average, and hospitals generated 16,833 on average. Those are awfully small numbers of things for a full year. So clearly this is just a very baby steps into a program of this sort, which again makes sense because the actual law, the actual regulations were not in effect yet. So of the things of the GFEs that were actually generated, 71% of them were generated manually, 11% used some type of automation, and the other 14% they don't know. Well, another 14% they don't know about. I think there was 3% that were put in some kind of other category, or something like that. So, what's also interesting is that 40% of them were communicated via the phone, 15% sent via postal mail, 10% email, 10% in the patient portal, 17% was grouped as an other that they note was probably handed a piece of paper in person, and 7% were unknown. Now, the good faith, the No Surprises Act allows for all of these mechanisms, but if it's done via phone, you also have to provide a paper format, not a paper, a written format of some sort. I also find it somewhat encouraging and interesting. I know that a lot of people have been talking about the patient portal being something they're really pushing. And it is in the law itself, it is the patient's choice as to what format they want. So I do find it encouraging that the patient portal did not overwhelm the other numbers. It means at least for now there's some reliance on being able to do other mechanisms. The other thing that I found interesting was the amount of time that was spent generating each GFE. And I don't know if it's totally a difference in the type of services or if it's the level of overhead and the number of people that had to touch them. But the small group spent about 5 minutes generating each one, while both the larger groups in the hospital spent about 30. One of them was 30 minutes and one of them was 31. So you can find the full report at that link. It doesn't contain much more information than what I have in the slide, but it does have some graphics and a little bit of more context on some of these things. Any questions or comments? All right. Well, hopefully they'll do another one next year when in theory the requirement was actually in place, at least for uninsured and self-pay patients. All right, let's move on to the next slide then. So HHS has released a series of infographics on different elements of cybersecurity to help organizations, particularly small organizations, organize themselves and implement best practices around cybersecurity. So some of the topics covered, I'm not going to just read off all of them on the slide, but a lot of these are fairly common, but it also talks about things like vulnerability management and specifically medical device security. Um, and so there's a little section on each of these and a few other areas. And I thought it was, for those folks who are visual and graphically oriented in terms of the way they best absorb information, I thought it was a pretty interesting set of stuff. And I recommend taking a look at the link below. Any questions or comments there? All right, let's move on. So this was also interesting. CMS released its 2022 Administrative Simplification Compliance Review findings. So this is basically who is out of compliance with the requirements for X12 transactions and using CAQH core operating rules. And so what they did was they took a look at different specific transaction types, and then they looked at the operating rules together collectively. And what they did for each transaction was they provided the total number of violations, which I list below. But they also talked about like the 2 to 4 most common types of violations and why it matters that these were not that folks were not in compliance and how to get more information about that. On the operating rules, they provided less information. It was all one collective section. It wasn't split further. And it was just a little bit of information on the most common violations. As you can see, the number of, and then these are just violations that required some type of corrective action. So there may have been other minor violations that didn't require, um, you know, that didn't reach the level of requiring a full corrective action. But as you can see, the numbers are fairly low. And the one thing that in the operating rules, a fairly large percentage of the violations of the operating rules were related to electronic funds transfer and remittance. So you can find the full document there with more information about the different violations and what the most common ones were and their thoughts on them at the link. But it's sort of a an interesting take. And like I said, it's sort of nice to see that the numbers were fairly low. Any questions or comments there? All right, let's move on. This is another, to me, it seemed like a poster. The first slide, I guess, is vaguely an infographic. It's sort of a 2-page thing. With the Office of Minority Health is trying to increase the use of Z codes for collecting S2H information. And so the first page is kind of it reminded me of like one of those old children's games where it's kind of a winding path and you make your way across the path. Uh, so it has sections along the path with different topics, and these are the main topics that are there. Uh, and then the second page is a list of common Z codes, and they kind of highlight the stuff that's newer. It lists all of the categories of Z codes, but it only lists specific codes under the categories. If some new code has been added since October 2021, it does in general indicate the dates that those codes were added, except it notes some as new, and on the ones that are noted as new, some are explicitly noted as October 2023, and some are not, and that's not clear why. So that's the one thing I would tell you. But it is really slightly future facing, so it will be good when the new stuff goes into effect. New codes are adopted in April and October of every year. In theory, although it seems like the Z codes do tend to be more in the October batch. But in any case, it's kind of interesting, and it's a good way at a glance to see what's new. And I thought the first page was kind of a nice poster. that was still informative. So any questions or comments there?
Yeah, I actually liked seeing that. I know, I want to say about 3 years ago when SDOH really kicked off, the biggest issue was, well, they're not paying for this, so why would I do it? And Z codes was the only thing you could remotely think of to get reimbursement for, and there were so few of them. So it's good to see the new ones added on there to help providers actually utilize it
Yeah.
more often.
It is, they are slowly adding some more. It's definitely not the best representation of all the different issues. Like I know, for instance, transportation and security just got added last year. So like it's really not necessarily keeping up with the various areas. I mean that's really considered one of the big three, and it wasn't covered at all until last year in the Z codes. So it's really it will be interesting to see how that further evolves. But I know from a data collection standpoint, um, on the provider side, there are other code sets that are much more interesting and useful and verbose in terms of what is going on with SDOH. Obviously, this is the one that can be sent along with billing. So that's also an important factor. Any other thoughts or comments there? All right, let's go ahead and move on to the next slide. So I believe this is the last update. I wanted to mention this because we've talked about it before and CMS has been hyping it. Their new website was launched. I've got to tell you that it's not a huge difference. There are the navigation was improved slightly if you like reactive contextual navigation. There's a little bit of spiffing up navigation and maybe slightly on look and feel, but I'm not positive that I would have realized that it was a site update if I just randomly showed up there without knowing that it had happened. So it really was some changes around the edges, and not I was expecting a much bigger reboot based on the way that they had advertised it. So I thought that was interesting. But in any case, if you're interested in poking around, feel free and take a look, and maybe the navigation improvements will make a significant difference for some people. Any comments or thoughts there? All right, then let's go ahead and move on. And if you'll pause there for a second, I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. You'll also see that email address on your screen.